Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Zainab Saeed, and today I'm going to talk about stroke prevention in atrial fibrillation. Particularly, we will be discussing the role of direct oral anticoagulants versus warfarin. Briefly, I'm going to discuss why I chose this topic. As we all know, atrial fibrillation is the most common cardiac rhythm disorder worldwide, with more than 1% of general population being affected. This in itself is a significant risk factor for stroke, and hence the need for anticoagulation and its prevention has been studied. And recently, a lot of researches has been ongoing, which have revealed that warfarin is inferior to the direct oral anticoagulants. Briefly, let's discuss what atrial fibrillation is. This is a type of supraventricular tachycardia that is characterized by rapid, disorganized electrical activity in the atria that leads to loss of effective atrial contraction. On the ECG, it is characterized by loss of P waves and irregular RR interval until and unless there is a complete AV block. The management is a complex decision which involves three basic criteria. First, there is rate control. Then we have to manage rhythm, and accordingly, we have to decide whether or not to start a patient on anticoagulation. Moving on to the pathophysiology of stroke, atrial fibrillation is a prothrombotic state, which predisposes to stroke, which is the most common complication. In itself, it causes stasis, endothelial dysfunction, and hypercoagulability, which is the vicious triad leading to thrombus formation, and this thrombi can then embolize to the cerebral artery, most commonly the middle cerebral artery, causing ischemic stroke. Clinicians have been aided by use of risk stratification tools. NICE suggests the use of CHA2 DS2 VASC score, which has superseded the CHAD S2 score. This involves 9 criteria. One being congestive cardiac failure, hypertension defined as hypertension of above 160 by 110, uncontrolled on medication. Age above 75 carries a score risk of 2, whereas age between 65 to 74 carries a score risk of 1. Then any previous history of stroke or transient ischemic attack or any vascular peripheral arterial disease in itself carries a score of 1, with diabetes mellitus carrying a score of 1 as well. The female sex in gender has a score of 1. Deciding upon this, anyone with a score of 0 requires no treatment, whereas anyone lying between 1 has moderate risk. This does not apply to females as their 1 score is only reached due to their gender. A score above 10 indicates the need for anticoagulation. The decision to start on anticoagulation has to be balanced against the risk for bleeding, which is a major adverse side effect. For that, the Hasbled score has been used, which involves the criteria of hypertension, abnormal liver function test, stroke, bleeding tendency, and a labile INR with an age above 65. Any score between 0 to 10 includes low risk, whereas anything above 3 is a high risk of bleeding. Then there are certain absolute contraindications which have to be considered before starting a patient on any anticoagulant. This involves any active serious bleed going on where the source has to be identified. Also, it involves this high-risk bleeding events such as intracranial hemorrhage, associated comorbs such as reduced platelets below 50, and any severe anemia. Once the decision has been made that the patient needs to start on anticoagulants for stroke prevention, there are certain therapeutic options between which the clinician has to decide. There is a vitamin K antagonist warfarin, which has been used in the past. This has shown to be effective, but it required INR monitoring. And now there has been a shift to the novel oral anticoagulants. In oral anticoagulants, we have two further subgroups: the direct thrombin inhibitors, which includes drugs like dabigatran, and the direct factor 10A inhibitors, including rivaroxaban, apixaban, and edoxaban. Discussing the case for warfarin, many studies had been conducted between the 80s and 90s, which showed that warfarin had a 68% risk reduction in stroke compared to placebo. But it had certain drawbacks that regular monitoring of INR was required, and an INR between 2 to 3 had to be maintained. Anything below 2 increased the risk of thromboembolism, whereas anything above 3 led to major hemorrhage. Still, warfarin was shown to be superior to aspirin monotherapy and even dual antiplatelet therapy. When warfarin was compared to aspirin alone, it was shown that aspirin had no mortality benefit, whereas it carried a higher bleeding risk in some trials. Whereas when it was compared with dual antiplatelet, including clopidogrel with aspirin, it was shown to be inferior, and the study trial was stopped early due to serious bleeding risks. As discussed previously, warfarin has certain drawbacks, particularly the narrow therapeutic index of INR between 2 to 3, which had to be monitored frequently, requiring hospital and clinic attendance by the patients. Then there were noted to be numerous drug and dietary interactions, which led to the development of the novel oral anticoagulants. These have been shown to have a rapid onset of action, and they have reduced monitoring and reduced interactions with different drugs and diets. Briefly discussing the comparison, we can see that warfarin has a slow onset, whereas oral anticoagulants show rapid onset with a wide therapeutic index and minimal interactions. In terms of variability in their anticoagulant effect in different populations, warfarin had high inter-individual variability, and hence the dose had to be frequently changed accordingly. Whereas oral anticoagulants provide a more predictable effect, and hence a single standard dose can be prescribed. Now, discussing individually the trials which have been carried on the drugs. First, let's talk about dabigatran. The major trial which showed superiority to warfarin was the RELY, which is the randomized evaluation of long-term anticoagulant effect. In this study, including patients who had non-valvular atrial fibrillation and a score of above 1. Two doses of dabigatran were involved in this, a lower dose of 110 and a higher dose of 150, and they were respectively then compared with warfarin. The results are summarized in this bar graph. The summary of the results showed that dabigatran, when used in a higher dose of 150, has shown clear superiority to warfarin in preventing stroke and major risk bleed, whereas there was a certain drawback which led to its discontinuation among patients, that was dyspepsia. Dabigatran also showed some increased risk of MI, although the statistical result did not reach any significance. Now, moving on to the other group of direct factor 10A inhibitors. These include majorly used drugs, and these are rivaroxaban and ipexaban. Two studies were conducted for these drugs to compare them with warfarin, including the Rocket AF and the Aristotle trials. The results are summarized in this bar graph, which show that rivaroxaban was not superior to warfarin in preventing stroke. However, it led to less bleeding episodes and hence was preferred by clinicians, whereas ipexaban had a clear superiority to warfarin in preventing stroke. Uh, However, still are certain limitations that clinicians face while prescribing oral anticoagulants. These include mechanical heart valves and a moderate to severe mitral stenosis, which is a valvular atrial fibrillation. In that case, warfarin is still the drug of choice for stroke prevention. Further, their doses of oral anticoagulants have to be prescribed carefully in renal failure. It needs adjustment in the range of moderate failure between 15 to 30 ml, in which case the doses are half. But below 15 is an absolute contraindication. To summarize this, we can safely conclude that anticoagulants are an important strategy to prevent stroke, and the direct oral anticoagulants have superseded warfarin in their safety profile and in administration. These are the references. Thank you.